Hello, and welcome to another episode of Office Hours and Revenue Cycle Optimized. I'm your host, Stuart Newsome, and this week we thought we'd do something a little different for you. We've actually compiled three of our most popular prior authorization episodes, starring yours truly, Stuart Newsome, as I'm going to be discussing why prior authorizations are still denied after approval. We're also going to include an episode from our Senior Solutions Manager, Stephanie Chang, as she actually is going to provide pointers on standardizing prior authorization workflows. And then lastly, we're going to include our Senior Manager of Patient Access, Jennifer Glockson, as she reviews insights on the 2024 prior authorization final rule. We hope you enjoy today's episode. Can you describe some of the most common bottlenecks healthcare providers face in prior authorization processes?
Of course. Here are some of the bottlenecks that I can think of that comes to mind in terms of healthcare providers facing in the prior authorization workflow. So one is lack of uniformity in processing the prior authorization requests. To know how to initiate the prior authorization. Is it going to be through a web portal, phone, or fax? Like these are kind of muscle memories that the PAs really have, and I give them all props. And also tracking the prior authorization process as well. Of course, prior authorization could come in all different sizes where you're tracking it in the EMR system or a paper or sticky notes. It could be a stack of paper that you just have on your desk. So tracking it to the finalized determination and having that crucial information documented somewhere safe for the backend to work is really important. And then two is the manual between systems. So there's a couple of systems you can already think of that you guys will use to manage prior authorization workflow. So like an EMR, EHR, practice management system as well could be scheduling tools and reaching out to the payer. So the management of multiple communication channels between providers, patients, and insurance companies often leads to error and further delays and overall increase in manual effort that takes away from the patient care.
What are some of the effective strategies that you've seen for consolidating and standardizing prior authorization processes across multiple locations and even practices? I've been waiting to get to this question because I know you've lived this, right? You've actually seen it and felt and understand it better than anyone.
Of course, yeah. So it really depends on your size of business as well. It does affect you in different ways. So, for example, if you're a smaller business, it does affect you in terms of different departments and consolidating the workflows within different departments. Of course, if you guys are a bigger client, an enterprise client, you guys will have different clinics, different locations. And with that being said, there's a lot of different probably workflows that people use for different departments within that as well. So consolidating processes is a huge beast. And what I usually recommend is implementing a unified process for handling prior authorization workflows across departments that will help reduce the confusion in terms of where data lives. So someone can pick it up where you left off, right? Minimizing errors so that you know where the data sits, so that the data that is sitting there is it's what you can trust. It's the most updated version. That's where you're going to find it there. And then speed up decision making overall with patient care. And some of the things that we can consider is creating a standard template. I know from talking to one of my clients that you might have the capability of creating a standard template in your EMR system that has all the questions outlined and capturing the information, even though if the question doesn't really pertain to the procedure that you guys are talking about or the visits at that time, at least it gives a reminder to the doctor to ask those questions so you have that documentation there. That can also be tailored to different modalities where it could be, for example, like ortho has different modalities that's under that specialty as well. So like surgeries, imaging, injections. I know there's different criteria that you guys can document in your EMR system to help with the prior authorization workflow. Two is simplifying your workflow. So having another tool that can consolidate your prior authorization workflow where you're able to initiate track your authorization workflow, and also have a documentation of where it lives and it has a single source of truth. So you can always go back to it and verify that information, or ever, if you ever need to look back on it, you have the capability of doing so. Three, I was thinking about integrating with your system with a tool that can help process your prior authorization. This reduces the data entry from one system to another system, decreases errors overall, increase efficiency with technology that can help track your updates.
Awesome. And that all sounds like a really good plan. But now kind of where the rubber meets the road, how like a real life experience involving, what you've just stated. So can you share a case study or an example of a healthcare entity or a client that successfully standardized their prior authorization workflows? What were the key steps that they took?
Of course. Yeah, this is a simple one. And I'm sure there's many other case studies that we can talk about. Here's one where several clinics has merged into one umbrella group. So there's 3 different clinics, let's just say, and each clinic capture data differently. And we have some that are capturing from the paper documentations where doctors actually walk into the patient's room with the piece of paper. This is the procedure that we're ordering. These are the diagnosis code. These are the information that I'm capturing, and then they hand it off to a scheduler to schedule. And then so capturing data differently, and then so making information difficult to access from one place to another, or one person to hand off to another, and then workflows in inefficiency. So by implementing like a training of some sort to help standardize where their data is going to live, what workflow is going to be, so that we draw out, hey, this is the actual workflow that we want to abide to. This is how we're going to get every department to adopt it. Consolidating that workflow by producing like an SOP document, putting in where to put that information, making sure where to update that, so that everyone has a single source of truth in the system. And that will significantly improve the overall operation efficiency and increase coverage if someone was to be out. And pick up where they left off.
Oh, that's awesome. And I like how, we do have a lot of case studies of, we have many website. So I definitely encourage everyone to go out there and download some of those case studies because they're real live events based on how customers have implemented these processes, and also combination of, I guess, tech and services in that mix, but also just what their roles were in that process, and some of the behavioral changes that they were able to institute. But it is an easy lift. It's, like you said, with training is very important for the staff, and then have that change and be willing to that change. But it's change for the better, obviously. Now, and I mentioned kind of technology, and you did as well with the integration. But what role does technology play in streamlining prior authorization workflows? Are there any specific tools or softwares that you can recommend?
Yeah, it's hard to recommend just one, but here at Infinix, of course, we have our prior authorization solution software called Patient Access. So in the traditional prior authorization workflow, of course, you're either calling and you're managing the data on the verbally, or if you're initiating the process on the web portal, you're managing the data from one system to another portal. So I would say invest in a specialized software that automates and track the statuses of each authorization request, where you have one tool that has the capability of initiating and then tracking the auth status, and then of course tracking your finalized determination, like I mentioned, where you can always go back to look for that data. And tools often can offer templates and standardizing form and reporting mechanisms that can help maintain consistency across all cases in that workflow.
Top denials are always released Every payer does it. Medicare especially does it. You can get those stats anywhere. And we're finding with prospects that it kind of mirrors what the national averages are. But the number one denial always seems to be prior authorizations or denials due to prior authorizations. In fact, the last couple of years, it's been 50% of the denials. So not only is it the top denial, it's almost half of the reasons that claims are denied. And to me, that's just crazy, especially if it's been approved, right? And you should have no problem getting paid. Now, if you didn't get a prior authorization and you get a denial code due to lack of prior authorization, then shame on you, shame on us, right? Because there are things in place, there are parameters in place. As frustrating as it is, for whatever reason, most payers will deny on average 15% of claims. And the main reason, because they can, because they want to. It's just something they do. I know they give you these CARCs and these RARCs and these reason codes, and there's a whole other process that we can talk for another hour on about how you can utilize those CARCs and RARCs and get to the root causes and be sure you mitigate those denials. But considering the fact that they just deny claims anyway, just because they can, it's really kind of absurd. I think everyone would agree with that. But another reason why payers may deny for no particular reason that doesn't make any sense is there's a lot of misinformation within the payers themselves. I think there's a lot of assumptions that the payers have it all together. They have all these rules and guidelines in place, and there's a lot of sharing of information going on within the payer organization. Like I said, that's not the case. Many of you may be nodding your heads right now, and you've had a lot of experience speaking with payers in the past. And understand this full blown. We just actually spoke with a prospect just this week that was frustrated with this. So there's a lot of discontinuity within the payer organization where the left hand doesn't know what the right hand's doing. For instance, this particular scenario with this prospect is that she knew what was covered, what covered procedures were, but she also would call in through those manual processes, dealing with phone calls and trying to connect to get the prior authorization done. As we all know, it's a very laborious process. And even though she knew that there was covered services for what she was trying to submit it for, she still would go through the process to make sure she got that prior authorization. And so she had a list of what was covered services, and they were agreeing. So, yeah, you're granted prior authorization. This is approved. And then when she turned around, she got the denial, and the denial would actually indicate to her that, no, this is an experimental procedure. Okay. So after a few times of this going on, she finally got someone on the phone and said, okay, do you understand that you've just agreed that this is a covered service? I'm looking at your policy that this is a covered service, but do you realize that you're going to deny it as experimental? And the person on the phone had indicated to her, says, no, this is approved. The person on the phone had no idea that this was on the back end. So there were instances where there was two different entities within the same payer that were functioning like this. And it's kind of like a practice. And we'll get to this at the end a little bit, but sometimes there's silos within practices where certain departments won't communicate with each other. Well, it's the same thing with payers. They're siloed. Everyone has a certain job to do. They put their head down and they do that job without looking up and seeing exactly what the considerations are around them. So with that in mind, there are a lot of disparities with discontinuity with the payers and the fact that they just flat out deny claims, again, because they can. And so we'll dive into some of those reasons behind that statistic of why it's 50% of denials are based on prior authorizations. But the first reason has to do with change in patient's coverage. Now, that's just a nemesis that practices forget to check. They take for granted that the patient came in to see the physician. They ordered these tests, or they ordered these procedures, or this surgery was scheduled, or whatever it is. They go ahead and apply and get the prior authorization. It gets approved, and then the patient comes back in to get admitted for the surgery, or maybe it's an outpatient type of a deal, or maybe it's just a test. And then the insurance has changed for whatever reason. The patient may have switched jobs, either willingly or unwittingly. People get fired. And so unless they're on that COBRA plan, which can be very expensive for them, then their insurance may have changed. Then their plan details may have changed. So the new insurer may not honor that previous prior authorization. In fact, I know they're not going to honor that. So this can be a significant issue, leading to unexpected denials. So changes in insurance coverage are a very frequent cause of denials, as each insurer has different criteria and coverage policies. Now, obviously, the way to remedy that is not only to ask them if they've had to change insurance, because obviously you can do that. Just about every practice does that. That's routine. But are they really telling you that they've changed insurance? That's where insurance discovery comes in. That's where you need to run that eligibility and make sure that you have that coverage, that they are insured, or that they are a beneficiary of that insurance policy. And what does their plan details? What is their copay? What is their co-share? What are all those details that need to know? And don't take for granted that it's the same insurance for when they come in again. So it's really good to have that done ahead of time. So you know ahead of time, wait a minute, we got to do this prior authorization all over again, which actually delays everything. So if you don't do that, however, then you're just giving away the service for free. You're not going to get paid for that prior authorization, or because it'll be a denial. The other reason is authorizations expire. So just like claims have timely filing, so prior authorizations, they don't last forever. They're not perpetual. You can't just get one prior authorization and it just lasts until the surgery is complete. So if the surgery is not scheduled within those timely limits, then it's going to expire. And if you go through the surgery anyway, then it's going to be denied. So providers really need to keep track of these dates to avoid those denials due to any expired expiration. So ensuring timely administration of services within that authorization period is crucial to avoid any unnecessary denials. Now, another is also where the services are just not matching the authorization. I'm going to touch on this a little bit later as well, but the actual service provided must match what was authorized. That seems pretty obvious, right? But any discrepancy, changes in the specific procedure or medication, can result in that denial. Many times there's perhaps the diagnosis code is billed with the claim that was not originally dictated from the documentation for the reason for the prior authorization. So in many instances, you got to have that correlation. You got to have your own continuity. We discussed a discontinuity of payers earlier on. Well, let's talk about that discontinuity on this end. So what your patient access personnel did, what your intake people were doing, your prior authorization team, whatever information they used to obtain that prior authorization needs to also match with what's going on with the claim. Then another reason is there may be an emergency of changing the procedure, either during the procedure as the physician is performing the surgery or performing the test, whatever the case may be, or even prior to. So going on here. For example, an authorized laparoscopic surgery might need to be converted to an open surgery due to complications. That's a pretty common one. And so that, believe it or not, that one little change, I mean, you're accomplishing the same thing, literally, but rather than laparoscopic, you're going in with open surgery, but it's a different CPT code, and you just don't need to give them a reason to deny, right? Now, even though it may be the same means to the end, you have the same diagnosis, but mitigating circumstances caused the physician to actually go in with the open process. You're just giving them a reason to deny it because the codes just don't match up. So any unforeseen complications often necessitate these changes in treatment plans, which can result in denials, but just make sure that you promptly update the information to the insurer. We're going to talk about the final rule that came out last month, January 17th. It's officially called the CMS-0057-F final rule. And we're going to lay out exactly what does this mean? What's the impact to not only practices, but also the impact to payers, because there's a lot of requirements that payers have to meet. And most of these changes are going to go in effect January 2027, but we'll later. But I mentioned that date because typically when a final rule like this comes out, and there's a date that's so far off because everyone's thinking, wow, that's 3 years away. What are we going to do between now and then? But there's a lot of things that have to go in motion. Anytime there's legislation that comes out, and it affects IT vendors in particular, I'm very appreciative, and Infinix is very appreciative. I'm certain EHR companies and PM systems and even clearinghouses all appreciate the fact that give us some time to actually implement this. But we're going to uncover some things that this may not be as new as we like to think. Now, the purpose, obviously, is to improve the electronic exchange of healthcare data, as well as streamlining the whole prior authorization process. And I know probably getting a lot of amens out there for that. A lot of gratitude that goes along with that. This really isn't the first time Medicare is requiring prior auth, right?
No, so this actually isn't the first time that they're requiring prior auth. Back in 2023, CMS did assign 53 codes that now require prior authorization for your traditional Medicare Part B patients. And this diverges from their previous policy that for Medicare Part B patients, there were no auths required for the Part B services.
Right, right. And I'm sure that probably took a lot of people by surprise.
It did.
I can only imagine. And even though the final rules come out, it's almost like they're telling you what's going to happen before it happens. They even do it in a proposed rule format. Anyone that's ever read the final rule, it's really good bedtime reading. But not a lot of people dive into that because it's a lot of pages, it's a lot of redundancies. You really have to have a discipline to motor through it. But there are those who probably did get caught by surprise by the fact that, oh, wait a minute, what's happening? It's affecting denials, it's affecting injections. It really breaks down the whole RCM process. So, Jennifer, let's talk about the impact or the benefits, if you will, that this will offer providers.
So the biggest benefit is that it's going to offer providers and facilities savings, right? So in the 2024 CMS ruling, it's a huge win for physicians and practices. The AMA is projecting that these updates and streamlining this process is going to save practices and providers around $15 billion over the next decade, just shaving down the time and effort that has to go into the prior authorization process. So it's a huge savings for the providers. So there's three major changes to this year's final rule. So the first big change is that by 2027, plans are going to have to start supporting an electronic interoperability between the provider's EMR and the insurance company. So this is set to include things such as, checking the prior authorization requirements, checking for clinical sufficiency, ensuring that there is a way for practices to electronically submit these requests and that the receipt of these requests are now going to be electronic. So this is great because it brings automation and efficiency to our current process that we all know is very time consuming and very manual, if you will, for a lot of these insurance companies. And obviously we all know how time consuming that calls to the insurance company can be for not only providers, but their clinical support staff, who would actually probably prefer to focus on their patient's care rather than filling out paperwork.
Right, exactly. It's always been a big headache for everyone out there.
Yes.
And that's where, you're thinking $15 billion over the next decade, where this is a large part of that. The time savings, your FTEs, your coders and billers and whatnot and schedulers who have to look into this, and repetitive, because it's something that you get denied. Then you have to, because you have to make a correction. It's rejected. Then you have to put in another prior authorization notice again and again and again. It's almost like, when can we get this pulled through?
The next big change is actually going to become effective in 2026. And this is going to be where carriers are going to be required to provide more specific and concrete reasoning for these denials. And not only will they have to provide a more clear explanation to providers, but they're also going to have to publicly report these metrics on authorizations. This is great because it requires insurance companies to provide physicians with a clear-cut reason for these denials so that providers and their support staff have better direction when performing things like reconsiderations, or if the doctor has to call to do a peer-to-peer, or if the office has to fight an appeal. It gives the staff a much more direct path on what we need to be looking at in order to get these decisions overturned. I think part of my favorite part of this is going to be the public reporting measures that these insurance companies are going to have to provide these metrics to patients who are searching to purchase coverage through the exchanges that are available as to how often that they approve and deny these services. They're also going to have to report to these patients how long it takes to process some of these requests. So I think in my opinion, it brings a much needed transparency and accountability for these insurance companies who in today's day and time tend to kind of pass all of the ownership off to the provider when a patient calls the insurance company to inquire about the authorization. This new rule is gonna force that insurance company to be much more transparent with the patient.